Narrow complex supraventricular tachycardia. Our module objectives. Define the umbrella term SVT and list and discuss its two divisions, the narrow complex SVTs and the wide complex SVTs. Recall and have a working knowledge of the common major narrow complex SVTs. Discuss the value of additional leads in the diagnosis of any arrhythmia. Discuss the limitations of using an SVT's rate to help identify a rhythm, and list and discuss the three most important complications that cause hemodynamic compromise in a rapid tachycardia. So a supraventricular tachycardia is a rhythm with a ventricular rate that greater than or equal to 100 beats per minute, where the rhythm starts or is maintained by tissue located in the sinus node, atria, atrioventricular node, bundle of His, or some combination of these sites. The atrial rates vary depending on the rhythm involved and can be found anywhere from 100 beats per minute to the mid-400s, or even higher in some rare cases. The tachycardia can be triggered by either an individual reentry circuit, like we've talked about with AV-NRT, or an individual focus. SVTs are broken down into a narrow complex tachycardias and wide complex tachycardias based on the width of their QRS intervals. Narrow QRS complexes are less than 0.12 seconds. Narrow complex SVTs are narrow because the ventricular depolarization wave depolarizes the ventricle using the normal electrical conduction system. And if you have a wide complex, it's because we're not using the normal conduction system. So technically, supraventricular tachycardia is any tachycardia that essentially originates from the bundle of His up, but not in the ventricles themselves. The term supraventricular tachycardia encompasses all fast or tachydysrhythmias in which the heart rate is greater than 100 beats per minute, and it applies to any tachycardic rhythm originating above the ventricle. Paroxysmal refers to the sudden onset and/or cessation. These are some of your most common major narrow complex SVTs, and it's sometimes hard to determine the difference between a couple of these. But you've got physiologic sinus tachycardia, focal atrial tachycardia, multifocal atrial tachycardia, AV nodal reentry tachycardia, orthodromic AV reentry tachycardia, junctional tach, atrial flutter, and atrial fibrillation. Three rhythms account for nearly 100% of the narrow complex SVTs. You have AV-NRT, which is around 60%, AV reentry tachycardia, which is 30%, and atrial tachycardia, which is 10%. How to approach a narrow complex SVT? Well, you're going to need to get a good history and see what their underlying history is. A good physical exam. Of course, we're wanting to see, are they hemodynamically stable or unstable? Underlying conditions, pre-existing conditions, presenting symptoms, maybe even a psychological causation such as anxiety. But always look at the company that it keeps. So another way to say that is to treat your patient first, then your monitor. Correctly identifying a rhythm from a single strip or monitor lead can prove quite challenging, if not impossible. The majority of the mistakes made in diagnosing arrhythmias occur simply because the clinician is looking at the wrong lead. We should always remember to obtain ECGs both during and after any episode of SVT. Comparison of the morphologies between the complexes during the presence or absence of the arrhythmia will provide additional clues that will make the diagnosis easier to obtain. Keep in mind that you may need a longer strip to evaluate a rhythm or event. Make it a habit to get a long rhythm strip when confronting a rhythm abnormality. Once we've identified our rhythm as a narrow complex tachycardia, we should evaluate the ECGs for the rate, regularity, P-wave, PR, or RP intervals, QRS morphology. Also looking for the presence of pseudo-R waves and pseudo-S waves. So these are two different examples of what we would call a SVT. Most likely a AV nodal reentry tachycardia, but this one has a heart rate of 250 and this one has a heart rate of 170. Both of them can cause physiological responses in the body. So we're going to look at the rate, the conduction ratio, the regularity, the P-wave morphology, the PQRS relationship. Is it AV node dependent versus AV node independent? So the rate can sometimes be useful in distinguishing between the various narrow complex tachycardias. The rate, however, is usually not extremely helpful because of the rates of the different supraventricular tachycardias overlap significantly. In addition, the rates for each SVT are the usual ranges for the tachycardia. Exceptions to the normal ranges are frequently found. For example, in focal atrial tachycardia, the atrial rates are usually found between 100 and 200 beats per minute. However, they can occur anywhere between 100 and 300 beats per minute. On rare occasions, rates of up to 400 beats per minute have been documented. Regularity. So most of your narrow complexes are going to be regular, with the exception of atrial fibrillation and multifocal atrial tachycardia, and these would be considered irregularly irregular. Your P waves. So a lot of times when it's going so fast, it's really hard to distinguish P waves, but an upright or positive P wave in leads 1, 2, AVF, and V1 with an inverted or negative P wave in AVR means that the origin of the tachycardia must be in the sinus node or the atrial tissue around the SA node. P waves are most prominent in leads 2 and V1. Lead 2 provides a clear view of the P wave. Lead V1 also has ideal placement since it's almost directly over the atria and can detect changes in both atria very clearly. Retrogradely conducted P waves will always be negative in lead 2 and almost always in leads 3 and AVF. The presence of these inverted P waves helps to isolate the pacemaker to either the low ectopic atrial area or to identify them as retrograde P waves. Always evaluate the morphology of the P waves for the presence of retrograde conduction. Retrograde atrial depolarizations are found in the junctional and ventricular rhythms, including the narrow complex tachycardias. The presence of the pseudo-S wave or pseudo-R wave is typical of AV and RT. AV node dependent rhythms are triggered at the level of the AV node or needed to maintain the arrhythmia. AV node independent rhythms do not involve the AV node. Most SVTs involve reentry mechanisms, a fact that is used in their classification into one of two groups: rhythms that have an ectopic focus triggered at the level of the AV node, or rhythms that need the AV node to function as part of the circuit to maintain the arrhythmia, such as AV node reentry tachycardia. The importance of this classification is to formulate treatment strategies, since AV nodal slowing or blocking agents will terminate the circular movement or work on the automaticity of a triggering ectopic foci. Pre-excitation. Always check for pre-excitation. It can be found only in patients with bypass tracts that allow antegrade conduction of the atrial depolarization waves to the ventricles. Therefore, these patients have to have at least two connecting pathways between the atria and the ventricles, the AV node and then the bypass tract. It is important to note that pre-excitation can be seen only when the patient is not actively in a tachycardic reentry. So the differential diagnosis, in order to get to the differential, you need to evaluate the information you've already gotten with your history, your physical, and even lab data, which is not going to be a luxury you have in the field. Narrow down the list until you reach the diagnosis.